Welcome everybody to another Medic Academy lecture review. The topic of discussion for this afternoon will be cardiology. Hey everybody, thank you for continuing with this lecture series. This particular part of the series, we're going to be discussing pathophysiology and where it pertains with the cardiovascular system. We're going to flip this camera around into the screen and we'll take it from there. So first we're going to take a look at pathophysiology. Now, in the previous video, we talked about anatomy and physiology. Pathophysiology is when things go wrong. When we're called on an ambulance, this is due to some kind of pathology. Chest pain is one of the leading causes that we get called for. And this pain is usually related to cardiac cell ischemia when we're actually talking about pain due from some kind of cardiovascular problem versus a musculoskeletal problem. So with cardiac ischemia, what we're talking about is that for some reason there's a decreased level of blood flow to the heart muscle, and this means that there is a decreased amount of oxygen being delivered as well as nutrients being delivered. So this tissue starves of these nutrients and oxygen and begins to die, gets sick, or it's ischemic. And if blood flow and oxygen and nutrient delivery is not restored, then it can infarct, meaning that this tissue is no longer as sick, it is dead. And that's when a heart attack occurs, myocardial infarction occurs. Now, ischemic heart disease is a disease that involves a decreased blood flow to one or more portions of the heart muscle, and this is one of the leading causes of heart attacks. Another, and this can be due to several reasons, but one reason in particular is atherosclerosis. Now, atherosclerosis is a narrowed blood vessel due to fatty deposits or plaque. Now, if you look here in this cross section, this is a normal artery. So the artery walls are clean and clear, and you can have normal blood flow. Well, with atherosclerosis, you have a narrowing of the artery due to plaque, and that causes abnormal and lessened blood flow. And when we have less blood flow to the heart, that means that our heart gets less oxygen and less nutrients. And this becomes extremely problematic when our myocardial oxygen demand increases. So, in times of stress or in times of physical activity, the cardiac oxygen, the myocardial oxygen demand becomes higher. When cardiac oxygen demand increases and we're not able to supply that oxygen demand, then we have chest pain and ischemia, and in some cases, infarct. And this can eventually cause a complete occlusion. A piece of this plaque can break off and become a thromboemboli, and then block this artery or this coronary artery, and cause a heart attack in that respect. Now, atherosclerosis, arteriosclerosis, can also cause reduction in blood flow. As I said before, this plaque causes narrowing of the artery wall so that blood could not flow appropriately. All right, so if we look here, we're going to talk a little bit about that thromboembolism I just talked about. And that's a blood clot that becomes lodged and stops blood flow to an area of the heart. If you look here in this diagram, in this picture, you'll see a clot. Well, this clot stopped blood flow to this area of the heart. So now this area of the heart begins to infarct. It starts to die. And with acute myocardial infarction, which is when that tissue starts to die, becomes dead, we can see things such as chest pain and a whole list of symptoms, which we'll soon go over. But we can also see cardiac arrest, and a lot of times cardiac arrests are due to an acute myocardial infarction, or AMI. And coronary artery disease in itself is the #1 cause of death here in the United States. Some major controllable risk factors for acute myocardial infarction One is cigarette smoking, high blood pressure, elevated cholesterol, elevated blood glucose levels, lack of exercise, and stress. And if you look at all of these things, there's a wide population of people here in the United States that have all of these risk factors. And the bad thing is these risk factors can be controlled. They can be lessened to lower your risk of a heart attack. But there are some things that we cannot control. One is getting older. The older you are, the higher risk you have to acute myocardial infarction, family history of atherosclerotic coronary artery disease, as well as being a male. Sorry, guys, you're more likely to have a heart attack than a female. All right, now that list of symptoms I just talked about and said that we get to later, well, now is later. And those symptoms are listed with acute coronary syndrome, or ACS. Now, acute coronary syndrome is any group of symptoms that is consistent with myocardial ischemia. And these can be a temporary situation in instances such as angina pectoris, or it can be a more serious condition such as the acute myocardial infarction we just spoke about. It can be hard to differentiate between the two because their signs and symptoms are very similar. They're treated in the same way under the designation of acute coronary syndrome. So we're treating it based on these symptoms, these signs and symptoms that we see. And a lot of times, the signs and symptoms that we see are very, very similar between the two. Now, with angina pectoris, is literally translated pain in the chest. This pain is caused when the heart tissues are not getting enough oxygen for only a brief period of time. They become ischemic. So oxygen demand goes up, but due to any given reason, there's several reasons. We'll take the most popular, which is atherosclerosis. Due to this reason, the heart cannot get the oxygen and nutrients that it needs, and it becomes ischemic. This ischemia causes pain. So now our patient is experiencing this chest pain. But this generally is relieved pretty quickly, especially with oxygen, rest, and nitrates. And there's no change in the heart rhythm with angina pectoris. Although this can also result from arterial spasming, but like I said, it's usually a symptom of atherosclerosis. Now, with this particular complaint, pain is usually described as crushing or squeezing, and the first time it happens to a patient is called initial angina. And this can be very, very scary for your patient because they're having significant chest pain. And we can classify angina pectoris as stable or unstable. But as I said, it can be very difficult to distinguish between a myocardial infarction, and we should treat it as an MI or myocardial infarction until we can prove it otherwise, until the physician can prove it otherwise. Now, this acute myocardial infarction we've been talking about is the leading cause of death in the United States, and 90% of deaths in this instance is caused by arrhythmias. Now, we can monitor for these arrhythmias because we're going to put our patient on an EKG monitor. And we should note and pay particular attention to any changes in rhythm. Now, these arrhythmias that we see happening, are treatable arrhythmias for the most of the time. They're very treatable arrhythmias. If not by an advanced EMT, but by paramedics and the physicians, if we tell them promptly that we see some kind of change on the monitor. So if the arrhythmias are the leading cause of death in these myocardial infarction patients and they're treatable arrhythmias, then most deaths from acute myocardial infarction are preventable if we can treat these arrhythmias. Pain of AMI signals death of cells in the area which blood flow is obstructed. And this could be more than one area. So, depending on where this obstruction occurs in the coronary artery system, then that area that coronary artery feeds of the heart is dead tissue. It starts to die, and it will get worse over time until blood is restored. Now, this can be treated with fibrolytics or angioplasty once we get them to the appropriate care facility. Which brings me to my next point, that we need to think about our transport decision with these patients. Is it better to take them to a local hospital, or is it better to take them to a facility that we know they can be treated promptly and appropriately with fibrolytic therapy and angioplasty? Some signs and symptoms of acute myocardial infarction include that sudden onset of weakness, nausea, and sweating, and pretty profuse sweating at that. Chest pain, pain in the lower jaw, arms, back, abdomen, or neck, an irregular heartbeat, syncope or dyspnea, pink frothy sputum, or sudden death is also a sign, a symptom of myocardial infarction. And these symptoms are not the same across the board. They can be different and vary from patient to patient, especially when we start talking about the geriatric population and females. They present differently than most patients. But the most common symptom of acute myocardial infarction is chest pain. Now, this pain that they'll have from acute myocardial infarction is different from pain from angina pectoris in three different ways. It may or may not be caused by exertion, and it can occur at any time, even when the patient is sleeping. So, with angina pectoris, this pain is usually caused during exertion. So, if patient is walking around Walmart and their myocardial oxygen demand goes up because they're walking around and exerting themselves, then they can start to have chest pain. And that's very typical for angina pectoris versus an acute myocardial infarction. They could be sitting on the couch watching Wheel of Fortune and start having chest pain. Now, AMI does not resolve in a few minutes. Rather, it lasts between 30 minutes and several hours versus angina pectoris, where it's easily relieved, especially with rest and nitrates. This patient usually takes nitroglycerin, or if they have a history of angina, then they'll usually are prescribed nitroglycerin, and this nitroglycerin usually resolves their chest pain in a matter of a few minutes. AMI may or may not be relieved with rest or nitroglycerin. As I said, we're going to treat them on the truck, especially with nitrates, for the most part, depending on where this acute myocardial infarction is located. And sometimes this may help, sometimes it may not help relieve any chest pain. Some physical findings that we'll see with AMI patients. One is frightened. They'll be very frightened. They'll have pale ashen gray skin. Generally, they'll have an increased pulse rate. Blood pressure will most likely be elevated depending on where the infarction is. And some areas of the heart, if it becomes infarcted, then their blood pressure will actually be low. But they do have a common complaint of difficulty breathing and feeling of impending doom, meaning that, oh, help me, I'm going to die. And that's a very bad sign in a patient. Now, this AMI can lead to sudden cardiac arrest, cardiogenic shock, or congestive heart failure. And as I said before, arrhythmias is a big deal with the AMI. Most AMI deaths occur due to arrhythmias. And this is an abnormality of the heart rhythm. And a lot of times they'll go into what's known as ventricular fibrillation. We'll learn a little bit more about heart rhythms here shortly. But not just ventricular fibrillation. There is a wide variety of arrhythmias that can follow at AMI. It usually involves PVCs, which alone are harmless and pretty common along the patient population. But coupled with an acute myocardial infarction, they can be particularly problematic. And we'll learn more about PVCs as well a little bit later on when we start talking about EKGs. There are some arrhythmias that we should look at, especially as, for this particular presentation, we're talking about advanced EMTs. Now, advanced EMTs should know the few rhythms. One is tachycardia, bradycardia, ventricular tachycardia, ventricular fibrillation, and systole. So with tachycardia, we're talking about particular sinus tachycardia, and this just means that your heart rate is over 100 beats per minute. With a sinus bradycardia, we're talking about a heart rate that is below 60 beats per minute. With ventricular tachycardia, we're talking about a very wide and fast heart rate. A wide complex and fast heart rate usually is about 150 to 200 beats per minute. And VFib or ventricular fibrillation, there is complete disorganization. There's no correlation between any of the activity you see on the monitor, and it's chaotic. This does not produce a pulse, where VTAC can produce a pulse. Sometimes it does, sometimes it doesn't. VFib, it will not produce a pulse and will lead to a systole if not promptly treated with defibrillation. All right, if you look here, we'll see a sinus rhythm, right? Or sinus tachycardia because it's above 100 beats per minute. Here we'll see sinus bradycardia, VTAC, which is wide and fast, VFib, which is wild and chaotic, and a systole, which we see no electrical current on this strip. And we're going to do a presentation. Matter of fact, the next presentation that you'll see, we're going to dive down into EKG analysis. So we're going to table this until the next presentation, where we'll actually look at some strips and we'll look at the paper and we'll learn how to read an EKG from start to finish. The next thing we'll talk about is cardiogenic shock. This is when the heart lacks the power to pump enough blood through the circulatory system. So it is, one of the four main types of shock. The heart can't pump the blood, so the blood doesn't get to where it's going. And this is often caused by acute myocardial infarction. Now, with cardiogenic shock, patients should receive the same initial evaluation and treatment as patient who reports chest pain. Pay particular attention to the respiratory effort in the presence of peripheral or pulmonary edema. The reason is that if you have a patient that's experiencing cardiogenic shock, then the heart cannot pump the blood that's coming to it. So one of the main places, especially if it's on the left side of the heart, the left ventricle can't pump appropriately, then we'll see fluid back up into the lungs. So a patient will have pulmonary edema, and this could be very problematic because they won't be able to breathe. So we'd have to correct this pulmonary edema as well as the cardiogenic shock, the actual hyperperfusion that the patient is experiencing. And with these patients, transport is very urgent. We need to get them to the hospital as quickly as possible to fix the pump. Some signs and symptoms of cardiogenic shock: one is anxiety or restlessness, air hunger, pale, clammy skin. And as shock gets worse, pulse rates will be higher than normal. The breathing can become rapid and shallow, nausea and vomiting, and they can have a decrease in body temperature. Some treatments that we should consider when a patient in cardiogenic shock: one is position the patient in a position of comfort so that they can breathe more adequately. Administer high flow O2, and if you need to, assist ventilations. Cover the patient to preserve body heat, because since they're hypoperfused, then they can become easily hypothermic. We need to gain IV access and give fluid boluses of 20 milliliters per kilogram of isotonic crystalloid solutions for the hypotension. And let's add in, we also need to listen to breath sounds, because this patient is not, if their heart is not pumping the fluid appropriately, then we really need to be careful with how much fluid we're administering to these patients. So if you hear rales or wet lung sounds, then now they have pulmonary edema, then we really should be careful with how much fluid that we're actually administering to them. And like I said, provide quick transport. With congestive heart failure, the ventricular myocardium is very damaged. So the ventricle can no longer pump blood that's coming to it. And this can occur after MI, heart valve damage, or long-standing high blood pressure. All these things can couple and cause congestive heart failure. Now, this heart failure can either be left-sided or right-sided. It's called congested because the lungs become congested with fluid once the heart fails to pump efficiently. So with left-sided heart failure, we see this pulmonary edema, With right-sided heart failure, we usually see a lot of peripheral edema. So when you think to differentiate between the two, just remember left is lungs, and that should help you out when trying to remember which side affects which area of the body. So, the left side is going to affect the lungs because we have all that blood that's coming back into the left ventricle from pulmonary circulation. So, if that left ventricle is not pumping the blood that's coming to it, then that blood backs up against that left ventricle. Pressure increases in the pulmonary circulation, and then we have fluid leakage into the alveoli, causing this edema. Some signs and symptoms could include orthopnea, which means that they have um, trouble breathing in different positions, particularly laying flat. Often mild or severe agitation because they can't breathe very well. Swollen ankles, or pedal edema. Sacral area can be swollen and have edema. It's called sacral edema. Hypertension, tachycardia, as well as tachypnea can be seen as well. Treatment for these patients, one is treated the same as for a patient with chest pain, especially if they're having chest pain. Take vital signs. You want to put them on the monitor, monitor their heart rhythm. Goes further than that, going to get you a 12 lead or EKG of this patient. Administer O2 and ventilate if they need to be. CPAP is very beneficial, especially with pulmonary edema patients. CPAP is amazing and is indicated. So, if their blood pressure is normal, as well, not normal, as long as their blood pressure is not low and they're able to maintain their own airway, try CPAP. It works very well, so as well as nitrates. Allow this patient to sit up with their legs down, and most patients experiencing pulmonary edema are going to want to sit upright and put their legs down. We need to gain IV access, and take the patient's medications with them to the hospital, just like you would any other patient. Nitroglycerin is very, very good in these patients. It works very well. So if we have this patient on CPAP and we administer nitroglycerin, what we're doing is we're lowering the amount of preload on the heart, so the heart can beat more efficiently, and we're reducing the workload on the heart by decreasing the afterload. So we're making these blood vessels bigger. The heart doesn't have to pump as hard, so there's less myocardial oxygen demand, and there's less preload on the heart with nitroglycerin. All right, so CHF and pulmonary edema are two different things. CHF can cause pulmonary edema, but there's many other things that can cause pulmonary edema. One is, another one is acute myocardial infarction, pulmonary embolism, hypertension, cardiomegaly. All these things can cause pulmonary edema, which are still treated with CPAP and nitrates. So we can see some hypertensive emergency. This is systolic pressure that's greater than 160, or have a rapid pulse, and that can be sudden, and severe headaches is a very common sign. Other symptoms can include strong bounding pulse, ringing in the ears, nausea, dizziness, as well as nosebleed, and this can lead to a stroke or a dissecting aortic aneurysm because of due to the high pressure that's in the vessels. We should position these patients with head elevated, gain IV access, and transport rapidly. And when we gain IV access, let's monitor these patients' blood pressure very, very well. All right, so we talked about that this hypertensive crisis can cause aortic dissecting aneurysm. Well, what is that? Well, aortic aneurysm is a weakness in the wall of the aorta. The aorta dilates at a weakened area and makes it susceptible to rupture. The aneurysm occurs when the inner layers of the aorta become separated, and this allows blood to flow between the layers, especially especially with hypertension, just because it elevates the arterial pressure greater than what it already is. And this ruptured aorta can cause immediate death. It's a very bad condition for your patient to be in, and if they don't die immediately, then they're going to be very, very sick patients. Some signs and symptoms where our aortic dissecting aneurysm can be hard to distinguish between that and acute myocardial infarction. Pain from AMI is often preceded by other symptoms, nausea, indigestion, weakness, or sweating. It tends to be gradual. This is pressure, and it's pressure, not stabbing. Now, pain of a dissecting aortic aneurysm comes on full force from 1 minute to the next. It can be tearing and burning sensation, and you could see a difference in blood pressure or pulses. And that concludes part two of this lecture series. Stay tuned for continuing with part three. Beginning in part three, we'll discuss patient assessment with cardiac emergencies as well as dive a little bit deeper into basic EKG rhythm interpretation. Y'all stay tuned and thank you for watching.